Hello, I'm Harold van Bosse. I'm a pediatric orthopedist, and today we're going to talk about orthopedic issues in Prader-Willi syndrome. The main orthopedic issues in Prader-Willi syndrome are related to developmental delay, flat-footedness, low bone density, hip dysplasia, and spine deformities, all of which we'll be speaking about. Underlying nearly all these issues is hypotonia, or low muscle tone, which we see in Prader-Willi syndrome. This is especially true in infants, leading to developmental delays. It also seems to contribute to the scoliosis, the hip dysplasia, and the flat-footedness. Let's start talking about developmental delays. Milestones can take twice as long in Prader-Willi syndrome compared to typical developing children. So for example, a typical child will start sitting at 6 months of age, and a child with Prader-Willi syndrome will start sitting at 12 months of age. Walking starts at 27 months of age in Prader-Willi syndrome compared to 12 months of age in a typical child. To address this, we need plenty of therapy, starting nearly as soon as the baby comes home, emphasizing gross motor milestones like crawling, and fine motor skills such as using their hands, as well as speech and swallowing therapy. If a child is not showing progress towards walking by 16 or 18 months of age, I prescribe ankle-foot orthoses, otherwise known as AFOs, to help stabilize the ankles and directly help stabilize the knees. This provides a better foundation for the standing child and allows them to progress to independent walking sooner. The parents in my clinic know that the motto is we get them walking up any way possible and then work on points for style. Here's what a solid AFO looks like, supporting the weak ankles. Hinged AFOs work well for conditions such as cerebral palsy, but do not stabilize the ankles well enough for Prader-Willi syndrome. Now let's talk about pes planus or flat feet. The child with Prader-Willi syndrome demonstrates in this photograph typical flat-footedness with the heel rolling to the outside and the forefoot drifting outwards as well. Because of their hyperflexibility and their low tone, children with Prader-Willi syndrome frequently have flat feet. This leads to poor foot positioning with walking and running, and discourages reaching with the hands because they are worried about losing balance. The treatment is bracing, rolling the feet underneath the ankles and straightening out the front of the foot. The bracing can be with supramalleolar orthoses called SMOs or with UCBLs. If the child was using AFOs to learn how to walk, we look to transition them once they are walking independently. This is what an SMO looks like. It comes just above the ankle bones, which are called the malleoli. What I don't like about them is that they don't extend the full length of the foot because the forefoot can drift outwards. I favor a brace that corrects the heel position directly underneath the ankle and pushes the forefoot over, which is why I like the UCBL style of brace. Now let's move on to osteoporosis and Prader-Willi syndrome. Studies of adults with Prader-Willi syndrome have found that up to 45% of adults have a history of a fracture. And identifying those fractures may sometimes be difficult due to the high pain tolerance of people with Prader-Willi syndrome. Adults with Prader-Willi syndrome have 20% decreased bone mineral density by DEXA scan compared to the general adult population. There have been no recent studies, but we'd expect that the regular use of growth hormone has helped the bone density issues. Treatment is prevention, using growth hormone, supplementing with vitamin D and calcium, and encouraging activity to load and stimulate the bones. Awareness of bone density issues is important, both in day-to-day life by recognizing the child that's favoring a limb may actually have a fracture, and in planning for surgery that includes bone. Next, we'll move on to hip dysplasia. On the left is an X-ray of a typical hip, and on the right is a dysplastic hip of an adult with Prader-Willi syndrome. You can see the difference in how the socket covers the ball of the hip. And on the dysplastic side, the ball is migrated somewhat to the outside. This is called subluxation. This can lead to arthritis and could end up requiring a hip replacement for pain. Reported to be somewhere between 8 and 30% in Prader-Willi syndrome. Despite that high rate, adults with Prader-Willi syndrome have a 2.5 times lower risk of needing hip replacement compared to the general population. This probably is because children with Prader-Willi syndrome are better at reshaping their hips with growth compared to typical children. Here's a 5-year-old, and we would say that those are some awful hips where the sockets are poorly covering the ball of the joint. This is usually headed towards surgery in a typical child, but by 10 years of age, the hip looks essentially normal for any 10-year-old. What's needed is careful screening. In the newborn baby, the hips are carefully examined to rule out a dislocated hip. If the examination is normal, I hold off on x-rays or ultrasounds since I don't want to overtreat the hips. I will get my first x-ray somewhere between 12 and 18 months old, when we get our screening x-ray of the spine as well. We always want to encourage as much activity as possible, having gravity go through the joint and the muscles around the joint working, which is the best way to develop the joint. If we see evidence of dysplasia on x-ray, we want to monitor the hips with yearly x-rays. If the hips stop improving or if subluxation develops, that is an indication for surgical correction. Now let's get to the meat of the matter, scoliosis. Children with Prader-Willi syndrome have a 60 to 70% chance of developing a spine deformity. 23% will develop curves before 4 years of age. And most of the rest happen around adolescence. 50% of children will need surgery for their curve. In a nutshell, if the baby's physical examination looks normal, I hold off getting screening x-rays until the child can sit independently, after which I continue to get yearly screening films. Curves under 25 degrees are followed closely with x-rays. Curves over 25 degrees need treatment with the goal of keeping the curve under 40 degrees, since curves of that size or smaller will not progress in adulthood. We need to remember that young children with Prader-Willi syndrome can hide curves, which is why screening x-rays are so important. The importance of treating these deformities is less about their appearance and more about chest wall deformity causing lung asymmetries, which compromise lung functioning. In severe cases, this can lead to heart issues as well. Treatment starts with prevention, delaying upright sitting until a baby can pull themselves into a sitting position themselves. That is to prevent hypotonic slouch, which we think can kickstart a curve. We emphasize prone positioning for activities, but not for sleep, which helps strengthen back and neck muscles. Physical therapy and physical activity are important. Children between sitting age and 5 years old with a large curve are appropriate for spine casting. In our study, about 1/3 of curves could be cured with casting. In large curves, casting can buy time, postponing surgical intervention to allow for growth. Here's a case of a child whose curve was cured. The 17-month-old had a 36-degree curve. After 5 casts, the curve was down to 11 degrees, at which time he was transitioned to a brace for a year. Here he is at 4 years old, 2.5 years after cessation of casting. This is a new technique for Prader-Willi syndrome, so we need to monitor these children carefully as they continue to grow. Now for an example of a controlled curve. This 18-month-old started off with a 106-degree curve. She responded well to casting. That's her in cast number 18 after 4 years of casting. By controlling the curve, she was allowed to grow to 6 years old before undergoing surgery. Bracing is appropriate for children too old for casting, either to prevent curve progression or as a way of allowing further growth while postponing surgery. Unlike casting, we don't expect it to make the curve smaller, and it's best for curves under 40 degrees. A typical example is this girl who started with a 32-degree curve, slowing progression to just over 12 degrees over 4 years' time. Prader-Willi syndrome doesn't always follow the rules, as with this 5-year-old girl with a 46-degree curve and nice flexibility. At 4 years into bracing, we were thrilled to see that her curve was only at 21 degrees. But there are no crystal balls and no magic bullets here. This 10-year-old with curves in the 30s should have done well with bracing, but her curves progressed relentlessly. Surgery is indicated for children whose curves are expected to be over 40 to 50 degrees by the end of growth, or those whose large deformities are threatening the development of their chest. The goal with the growing spine is to provide it support but allow it to keep growing. The goal with the nearly mature spine is to align it permanently in a stable position. We want to control the side-to-side deformity of the scoliosis, but more importantly, we want to end up with a well-aligned posture when looking from the side. We need to stay aware that there's a high complication rate for scoliosis surgery in Prader-Willi syndrome. For the growing spine, a non-fusion spinal instrumentation allows the spine to continue to grow. Here's my first patient with Prader-Willi syndrome with a manually expandable implant. That meant that twice a year we had to go to the operating room to lengthen out his spine. Here he is at 16 years of age at the end of treatment. Now, though, most of the cases are addressed with a magnetically actuated rod that can be lengthened in the clinic with an external electromagnet, such as with this 10-year-old boy and a severe curve. Here he is right after the rod's replaced, reducing his curve down to 55 degrees. You can see how much improvement he had after just 2 lengthenings. And here's my friend Dr. Cahill showing off how the external magnet is used to lengthen the rods. On the other hand, when the child is no longer growing, a simple fusion of the spine works well, as with this 15-year-old girl with 80-degree scoliosis. Her shoulders are not well centered over her pelvis, and she has an exaggerated kyphosis. 4 years after her fusion, she has much better balance of her spine on both views. Let me try to summarize my protocol for children with Prader-Willi syndrome. As newborns, they need a very thorough physical examination, particularly their spine and hips, but no x-rays unless there are abnormal findings. We start therapies and emphasize stimulation and activities, delay independent upright sitting. Once they do start sitting on their own, I will obtain the first screening sitting spine and supine lying down pelvis radiographs. For the spine, 25 degrees is a break point, below which a curve can be observed, but over which a curve needs to be treated, which in a young child means casting. As for the hips, as long as there is no subluxation, we will continue to monitor the hips yearly. And I prescribe AFOs if the child is not walking by 16 to 18 months. Once they are walking, we evaluate for flat-footedness. In scoliosis, if no curve is seen, I recommend yearly radiographs until they are 4 years old. And again, stringent monitoring at about 8 to 10 years of age. Curves identified between sitting age and around 5 years of age are appropriate for casting. Bracing is preferable for curves up to about 50 degrees. Expandable implants are for large curves in children between 5 and 10 years old, with spinal fusion best for children over 12 years of age. Initial hip screening x-rays are done at the same time as the initial spine x-rays. If dysplasia is identified, the hips are followed yearly unless subluxation develops or the improvement plateaus, which may be an indication for surgical intervention. Again, this is rarely needed. In under-resourced areas where it may be difficult to get braces or surgery, remember that therapy and activity are the most important. Make the children strong and keep them lean. I hope you enjoyed this talk. I look forward to hearing from you with questions you may have.